Lecture 1 in this introduction to the hernia course. We will review 3 topics: epidemiology, embryology, and C, patient assessment and diagnosis. Let's start with a very brief discussion on the prevalence of inguinal hernia. Indirect inguinal hernias are the most common type of hernia in both genders. In preterm infants, the incidence is 10%, whereas in full-term infants it is 3 to 5%. Femoral hernias are more common in women, while direct inguinal hernias are uncommon. In general, all groin hernias are 10 times more common in men. The lifetime risk of inguinal hernias is 25% in males and only 2.5% in women. Africa has a substantial inguinal hernia burden and limited surgical capacity, which means many patients live with untreated disease and often come after developing complications. The prevalence in Ghana is 3.2%, in Tanzania 12%, while among men in eastern Uganda the prevalence is 9.4%. Less than 1/3 of men in eastern Uganda with a hernia had been treated surgically, which results in a substantial untreated burden. District hospitals in rural sub-Saharan Africa are not meeting the population's need for hernia repair. Let's proceed to the embryology of the testicle and groin. The goal is a clinically relevant understanding of the embryology of this region. The groin is a complex anatomical region, and understanding it is essential for safe hernia surgery. The gonads begin development high in the retroperitoneum, arising from the genital ridge. As they descend, they create anatomic relationships that explain both the structures of the inguinal canal and the pathogenesis of hernias. To master hernia repair, a foundation in testicular embryology and its impact on groin anatomy is helpful. The testis begins as an undifferentiated gonad. This structure is derived from the intermediate mesoderm, one of the 3 germ layers of the embryonic disc. The intermediate mesoderm forms the urogenital ridge, which you can see here in the highlighted red region. This differentiates into distinct genital ridges, which give rise to the undifferentiated gonad. Migration of primordial germ cells from the yolk sac into the gonad, which is illustrated with arrows, completes the development of a functional testis. The origin of the gonads, high in the retroperitoneum before descending into the scrotum, is important, as this journey establishes the anatomic basis for the inguinal canal and its layers. Diagram A shows how the testicle passes from the retroperitoneum through the abdominal wall into the inguinal region, bringing a diverticulum of parietal peritoneum, the processus vaginalis, with it. Diagram B shows the processus vaginalis, which is obliterated. This occurs after the testicle has descended into the scrotum before birth or in early infancy. This is the normal process. The timing of the descent of the testicle is as follows. Around 11 to 12 weeks of gestation, the gubernaculum attaches to the inferior aspect of the gonad and pulls the testis downward. By the 16th week, the testis passes through the deep inguinal ring, and by 32 weeks, it crosses the inguinal canal and emerges through the superficial ring. As it descends, the testis pulls along the layers of the abdominal wall to become the coverings of the spermatic cord. The parietal peritoneum also sends a diverticulum known as the processus vaginalis. Normally, this obliterates. If it fails to obliterate, it leaves a patent processus vaginalis, which is the basis for congenital inguinal hernias, and hydroceles. The transversalis fascia contributes to the internal spermatic fascia, which is the deepest covering of the cord. The internal oblique muscle gives rise to the cremasteric muscle fibers, which are encountered during hernia dissection of the cord. Finally, the external oblique aponeurosis provides the external spermatic fascia, the most superficial cord covering. When we perform hernia surgery, we dissect these coverings to identify the hernia sac. Understanding the layers of the cord helps avoid injury to cord structures. These images summarize the entire process of testicular descent. In the upper image, at 11 weeks, the gonads are visible in the abdomen. In the next image, the descent at 4 months is shown. As visualized in the third image, we see that the testicle enters the inguinal region at 8 or 9 months under hormonal and gubernacular influences. If the testes fail to progress normally, it may result in an undescended testis. If the processus vaginalis does not obliterate, it may result in a hernia or hydrocele. Let's proceed to patient assessment and diagnosis. Patient assessment and diagnosis, including history and physical examination, is next. We will also discuss the differentiation between inguinal and femoral hernia and introduce several hernia classification systems. You, the surgeon, must personally see and examine the patient before they come to the theater. In addition to evaluation of the hernia, identify comorbidities that need optimization, like uncontrolled hypertension or a cough. Weigh the patient, as this is critical for calculating the safe dose of local anesthetic. The most common presentation of a hernia is groin swelling that comes and goes. This presentation is often related to activity. The hernia may be more prominent at the end of the day or after heavy lifting and often will reduce overnight. Most are asymptomatic or cause only minor discomfort. An important danger sign is incarceration when the hernia does not reduce, which is often painful, and, more seriously, strangulation may occur when incarceration is complicated by loss of blood supply to the hernia contents. This can be life-threatening. If the bowel is stuck, i.e. incarcerated, the patient may present with symptoms of intestinal obstruction like nausea, vomiting, and abdominal distension, which is a surgical emergency. A critical rule: do not operate on groin pain alone. If there's no palpable swelling or reliable history of one, the pain is likely from another source, and surgery will not help and might make it worse. Always have a differential diagnosis. A groin mass could be a lymph node, a lipoma of the cord, a hydrocele, tumor, torsion of the testicle, or even a femoral artery aneurysm. A good physical exam is key to sorting this out. Your physical exam of the patient must be dynamic. Have the patient stand, as this increases intra-abdominal pressure and makes the hernia more obvious. The key steps are: inspect for asymmetry. Ask the patient to cough or bear down Valsalva while you watch. Palpate by invaginating the scrotal skin with your fingertip to the level of the external ring and feel for an impulse during a cough. If the history is strong but the exam is negative, have the patient walk around or come back for a late-day appointment. Believe the patient. The patient may complain of a swelling in the groin, even when you cannot demonstrate it on physical examination. Precisely differentiating between direct and indirect hernias on physical exam is difficult and unnecessary, as the surgical approach is the same. It is crucial to identify a femoral hernia. When the bulge is below the inguinal ligament, near the pubic tubercle, consider the possibility of a femoral hernia. This increases the urgency due to the higher risk of strangulation for a femoral hernia. Inguinal ligament repair is not the correct surgical method. Femoral hernias should be referred to a specialist surgeon. On physical examination, you should try to determine if the hernia is direct or indirect, and also whether it is inguinal or femoral. As demonstrated in this illustration, inguinal hernias are above the inguinal ligament, while the femoral hernia is below. In these images, an indirect hernia is identified with the standing patient with the digit placed in the invaginated scrotum, while the direct hernia is identified as a direct bulge in the groin. Hernias are classified according to etiology: congenital or acquired, or by the occurrence of complications that should be identified, including whether the hernia is reducible, incarcerated, or strangulated. Note whether the hernia is unilateral or bilateral, and if it is primary or recurrent. Indirect hernias are congenital and are due to the lack of obliteration of the processus vaginalis. A positive family history is a risk factor when these hernias present in infancy or childhood. They are associated with a normal-sized internal ring, while in adulthood, they are associated with the widening of the internal ring. Acquired hernia includes both direct inguinal hernias and femoral hernias attributed to wear and tear stresses and associated with heavy lifting, chronic cough, straining for urination or defecation, and ascites. An indirect hernia is a remnant of the processus vaginalis. This sac leaves the abdominal cavity at the internal ring. It arises lateral to the inferior epigastric vessels, then passes through the structures of the spermatic cord for a variable distance. It may stay within the inguinal canal, pass through the external ring, or extend down to the scrotum. The indirect inguinal sac lies within the cremasteric muscle fibers anteromedially to the vas deferens. Indirect inguinal hernias are associated with enlargement of the internal ring, except in children, where the ring is of normal size. Thus, one needs to repair the posterior wall when treating an indirect hernia in adults to reduce the size of the internal ring. No repair is performed for an indirect inguinal hernia in children. In the direct inguinal hernia, the sac leaves the abdominal cavity through the posterior wall of the inguinal canal within the inguinal triangle, Hesselbach's triangle. It arises medial to the inferior epigastric vessels. Direct hernia are due to weakness of the posterior wall of the inguinal canal with protrusion of the hernia sac through a defect in the transversalis fascia. In a direct inguinal hernia, the hernia sac directly enters the inguinal canal through its posterior wall. Therefore, the sac does not lie within the cremasteric muscles. The direct sac lies posterior to both cremasteric muscle fibers and spermatic cord. A variant is the pantaloon hernia, where both a direct and indirect hernia occur in the same patient on the same side. During Lecture 1, we reviewed the epidemiology, embryology, history, and anatomy of inguinal hernia. Inguinal hernias, which are common and, if not addressed surgically, often present with complications. The descent of the testicle explains the etiology of an undescended testicle and the pathogenesis of indirect inguinal hernia and hydroceles. History and physical examination are important in diagnosing the type of groin hernia, which should be classified according to etiology and complications.